we also made the slides user-friendly so you can reference them. Together today, we're going to present our focus of the Department of Mental Health, our services, and our scope. One second. Oh. Okay. So the objectives of this training will be to increase the knowledge about the Department of Mental Health, to gain awareness of common mental health symptoms across the lifespan, and to increase knowledge about how to access mental health services. So we're going to begin just a review of the Department of Mental Health. We are the largest county-based public mental health system in the nation. We serve over 250,000 clients annually. We run and operate 85 directly operated sites. So those are DMH clinics, basically, with DMH county staff. We have over 300 co-located programs, and these co-located programs basically work with other county departments or other systems such as courts. An example of this would be we have DMH staff, county staff, co-located at Department of Public Social Services and at all the DCFS offices as well. In addition to that, we have we contract with over 1,000 organizations. These are your nonprofit organizations such as Pacific Clinic, Children's Bureau, etc., agencies throughout the county. And one of the major reasons for this is also to be able to reach all our clients, as it is, we are a very large county. So we want to make sure that we are accessible to our clients. So briefly, a little bit about the department and our mission and vision. We are in the business to optimize the hope, well-being, and life trajectory of our most vulnerable through the access to care and resources that promote not only independence and personal recovery, but also connectedness and community reintegration. We envision to create easy access to the right services and the right opportunities at the right time in the right place from the right people. Our main belief is that people actually do recover from mental health and get better. And we want to give our clients hope at the end of the tunnel. So this is why we try to help our individuals, our clients find hope. We want to do it with dignity, and we want to make sure they understand that they can recover, feel better, and be part of society. So everybody's fully aware of the scope of Los Angeles County. If not, however, we wanted to show a map of our county. We are in every service area, 1 through 8. We also ensure that this is part of the reason why we have to contract with some of our providers in order to make sure that we're everywhere. But our services are on Service Area 1, Lancaster, Palmdale area, all the way to Service 8, which is Long Beach. Okay. So who do we serve? Who are our clients, our population? We serve children all the way to, from birth, all the way to the end of life. We make sure that a lot of our programs have been divided between age groups in order to be able to have better treat our clients, because there are special needs. For example, 0 to 5 children have different needs than maybe older children, teenagers, or definitely adults. We also believe that transitional age youth, which is TAY, transitional age youth group, which is between 16 to 25 years old, also have different needs and than our younger youth and also than adults. So we make sure that we have some services that are developed and around their needs. Then we serve adults and older adults. The type of services or funding that we take are Medi-Cal. Clients can have Medi-Cal. Indigent funds means for clients that are unable to pay for services, so they have inability to pay for services or are not insured. We're able to provide services if needed. And we also have sliding scales for those that have some form of ability to pay. In order for you to understand our system, we wanted to, this continuum of care, we created this picture for you to understand the vast scope of our services. Most of our clients do not begin our services or seek out services at one point in time. Some of our clients start services really early on with no symptoms or mild symptomology. And some of our clients, their first initial connection with us is when they are psychiatrically hospitalized. So we have a different array of services to meet our clients' needs. And we're going to take a little bit of time in this continuum of care slide to kind of explain our vast programs that we have available for our community, and for you to understand maybe where some of your clients would fit in. So the very first one, prevention. The way we see prevention, we have two layers of prevention. We have universal prevention, which targets the general public or as a whole. The idea really here is to educate our people, our community, to understand what is mental health, how do people are able to do self-care and take care of themselves, what are the steps that you have to take in order to do that. Also just also understanding and in kindness to other people who are suffering mental illness as well. So this is like the universal, everybody understanding a little bit about mental health in general, mental health services, and what's going on in our community. Then we have selective prevention, which basically targets individuals at risk of developing a mental health issue. This not necessarily mean that the clients would actually have a mental illness, but this would refer to, for example, working closely for example, we're co-located in some of our DPSS offices, Department of Public Social Services, because we understand that some of the individuals that are attending or receiving those services may be at more risk of developing some or having or experiencing some mental health issue. So we make ourselves available in order to be able to be there for that connection. Some of our examples, this is not the one. Some of our examples of prevention would be partners in suicide prevention or stigma reduction. These are trainings that we provide in our community. We try to talk about how do you handle somebody who is probably experiencing suicide? What do you do? What are some of the steps that you want to take? Or stigma reduction. How do you understand people who have a mental health issue? What are they experiencing? How can we be kind and supportive to an individual who's going through something difficult? Okay. Then the next section is early intervention. These programs aim at treating an early diagnostic or individuals with basically mild symptoms. Some of these programs that we provide here are evidence-based practices that we provide, short-term therapies. We also have we also have some specialized programs for certain, especially for young children in school. Maybe they have experienced some things in the community, and then we provide some direct services. Then the next one, outpatient. This is something that many people refer to general outpatient. Many people are more used to receiving outpatient services, or when they think of mental health or therapy, they really think about somebody going to the clinic and seeing a therapist or a psychiatrist. This will be your outpatient services in which you go to the clinic and seek out services. Some of the examples, again, are general outpatient for our clients. We also have other programs such as Recovery, Resilience, and Reintegration Program. This program specifically is an in-between program from a client who needs some outpatient, meaning they can attend a clinic for services, but might also need some in-home services. So it's between a little bit of, they get a little bit of in-home services and a little bit of outpatient services. We also have other PEI programs, which is called Prevention and Early Intervention Programs. They're also provided at the clinic. The other section, intensive services, these services refer to individuals who have, these services are provided in the field. They're in-home services. They're different from all the other programs because they have a 24/7 response component for mental health emergencies. They have their own line in which the client is able to contact them 24/7. Somebody will be available on the phone. And in addition to that, if the client is in a real crisis, then somebody from that team will go to the home and assess the person if they need to be hospitalized or need some other additional assistance. These intensive services are for clients who have a more severe mental health issue. We have intensive services both for children, for everybody, for children, TAY, adult, and older adults. And we have some specialized programs for them. They look very similar, but they have some special components depending on the age group. One of the programs that you as a home visitor might have been able to refer to or would be able to refer to is really called Full Service Partnerships Program, FSP, which is basically a community-based program that is open for anybody in our community that meets a specific criteria. This information about this program can be found on our website. The details gives you details exactly of what is the criteria that you want to see in a client when you make that referral, and the referral is also on our website. But this will be a client that will be experiencing more severe symptomology. Prior to this area or section, outpatient services or early intervention services, you don't really need to do a referral. We'll talk a little bit about how you actually get a client into those services in a little bit. But intensive mental health services, you would have to make a referral for those services. Another example of it is day treatment intensive. Then we have our residential or other services. These residential programs are locked. Some of them are locked facilities for clients that need to be, they're conserved, for example. Also, we work in conjunction with our psychiatric hospitals. And the last section that we wrote here is our collaborations or co-locations. We wanted to give you an example of the programs that we actually have. They look a little different and they're a little specialized because we're working specifically with some of our partner agencies. Again, Department of Children and Family Services, Department of Public Social Services, Department of Health Services, Public Health, Los Angeles LEPD, with some school districts. We have specialized programs and we're co-located in some of their sites. So I gave you guys a little bit of information of the array of programs that we have. So the types of services that we provide are basically therapeutic services. We provide psychiatric or medication support, case management, support, and education groups. What makes each program unique and different is that they provide the same level of these same type of services, but they provide a different level. For example, an intensive mental health service would probably provide therapy 2 times a week, plus case management once a week, and in addition, it might provide an extra support of a parent partner or a peer advocate. So you would have somebody basically being seen maybe 3 to 4 times a week in an intensive mental health outpatient program. Versus a general outpatient program, somebody coming to the clinic could still get therapy and case management services and educational support, but it might not be every week, for example, and it would be at the clinic. But the availability of the services is there. So something very important for our department is being culturally humble. And this really refers to the fact that we have to start where our clients are. Culture is multifaceted. It's not necessarily just ethnicity. It doesn't necessarily just refers to somebody's language. It also refers to the experiences that the individual has had, sometimes trauma. Therefore, what we really aim at our department is really try to be culturally humble. We refer to treating each individual and family as an expert of who they are, and to let us know what are the needs that they have before we prescribe what we think they should when we prescribing what we think they should be taking. We like to listen to them. What are their needs? What are they willing to do? And an example of this would be a client that we really think might be beneficial to do intensive mental health services, but does not want to have somebody coming to their home. The services might be provided in an outpatient setting for some time, and with the hopes that building that rapport could allow us later on to be able to serve this client at a much better place, maybe at their home. We also employ staff with lived experience, and these are peer advocates and parent partners come. Our peer advocates and our parent partners are an amazing part of our department because they are individuals who have either gone through our system within Department of Mental Health. In other words, they've been clients themselves or were clients at one point, or had a child that was a client at one point. The beauty or the cultural piece that these individuals bring to our department really is for us to learn from them what are the needs of our clients, but also they help us connect as a department to our clients. And we believe that having our peer advocates and parent partners join our team have allowed us to have a better communication and better understanding of a client and really understand the culture of our client, of our community. We also provide multilingual and we have multilingual capacity. In Department of Mental Health, we provide services in the 13 threshold languages. We also provide multilingual and multicultural services in either through different programs that we have. For example, we have an API collaborative. We have the Latino caucus. So we ensure that we provide not only the services that are necessary and the languages that are necessary, but we also provide trainings and for our workforce so we can be better trained and understand our community's needs.
Hi, y'all. So my name is Geraldine Gomez. I'm actually an LCSW over at the Prevention Bureau with the Department of Mental Health. I'm going to be following up on Rebecca's end here. We're going to really go over what mental health is. Mental health is comprised of a lot of things. There's a lot of stigma and taboo surrounding mental health. And it really has to do with our emotional, psychological, and social well-being. In the Department of Mental Health, and especially now with the whole prevention movement, we've learned something that we all know, that everyone sees mental health differently, but there is a connection between body, mind, and soul, or your emotions. And so anything that happens in the mind affects obviously the feelings and can have a physical impact on an individual. And so mental health is comprised of, again, the emotional, psychological, and social relationships that a person has. It affects how we think, feel, and act. And those are within our experience in mental health, all interlinked into how we as to how we're doing on a day-to-day. It determines how we handle stress, how we relate to others, and make actual choices. So when you guys are doing home visitation, you're going to be encountering children, families, and we're presuming that families are comprised of adults, and it could be of varying ages. And so we're going to go into some of the basic symptoms that you may see present in some of the children that you see in the families that you visit. Most commonly in children, you can see changes or irregularities in sleep habits. Some children might sleep more or sleep less. Changes in eating habits. You might notice that they have an increased appetite or no appetite at all. And these, of course, are not related to the developmental phase that that child is in, whether it's a growth spurt or not. These are just typical changes that you might see. Maybe something happened, and as a result, the child is no longer eating after that. Emotional dysregulation, which really means that a child is not able to stop crying. For example, some of our most intense cases with children, you have children that are unable to stop being in the middle of a tantrum for 3 hours. They can cry and cry and cry. And so it's for a prolonged period of time versus your average child that might dishabituate or will be able to manage their own emotions within a certain period of time. And again, looking at developmental milestones, maybe you're seeing that a child is more sensitive to, let's say, like the tags on a article of clothing, or to sounds, or they're reacting to lights, or a certain type of noise. They don't do well when there's too much talking in the room, or they overreact when, or react differently when they hear something out in the community. So those are all indicators that something is going on, that these children are having a response to the environment, that something might have happened that may require mental health services. For the older kids, it would be for poor school performance. Maybe they're not getting along with their classmates. Some might be biters, or might fight, might not be able to get along. There might be bullying. So those are all indicators, again, that something's going on within their environment, and it's impacting their school performance. And they may be a good referral to one of our mental health services programs. Now, symptoms common in adults, and these symptoms could actually be found in any adult, maybe even children from the age of 16 on, which we would consider transitional age, all the way to the very elderly with very slight variations, but obviously prolonged changes in mood. You might have someone that can be extremely sad or down one day, or extremely happy, very energetic, talkative the next day, or if you know someone that's really pretty content with their life, or pretty happy-go-lucky person, and they start not being themselves, you notice a change, then that would be something that we would want to look at, that you want to pay attention to. Changes in sleeping and appetite, same thing as with children. Either the person is either sleeping too much or not sleeping at all, or they're waking up in the middle of the night, or just having difficulty falling asleep initially. Any changes in appetite, that would look like someone who is either increased in their appetite, they're eating way more than they normally would, or they're not eating at all. They're skipping their meals, they don't have appetite, and time is just passing without them really nourishing their body. Again, going back to that mind and body connection. Any unexplained physical complaints, and this is actually very important to notice, because, and it's not a symptom that we put in the kids section, but it's really important to note these, because a lot of folks from different cultural backgrounds don't say, oh, I'm feeling depressed, or I'm feeling anxiety. They say, actually, my stomach hurts, my head hurts, my shoulders hurt, I have lower back pain, or, I just don't feel like getting up. I feel really tired, very sluggish. These are all unexplained somatic complaints, physical complaints that can be linked to mental health services. And this again, might be a cultural thing, might be due to stigma. So these are always important to pay attention to. We would always want to rule out any medical organic origin. However, once that's been cleared out, then definitely something we want to take into consideration. The next symptom that we look at are changes in mental state or thoughts. And that actually is really interesting, because if you have someone that's pretty alert, pretty oriented when you talk to them, but when you go and visit them or you meet them out in the community and they present very disoriented or they're confused, you can always ask what day it is, where they are, to tell you a little bit about the situation they're in. It's good to be able to pay attention as to, are they able to process the information that you're asking? Are they able to provide the information? Do they know what's going on in their environment and with them? And maybe, they're having thoughts where they're not, where they're tangential or they're loose or they're not actually related to the questions that you're asking. Then again, something very important, something to note. You have adults that are seeing or hearing things that other folks might not see or hear. You have people that are talking to themselves. This happens a lot with the cases of like delirium, where you have older folks that you might go see and something medically is going on, and that could actually impact their thought process. And so they're talking to themselves or they're seeing things that aren't there. So always important to note, important to check in with that person. Hey, who are you talking to? What's going on? Just to get a better idea of what's going on, make a note of that, and then be able to report that when you're making that linkage or referral. Another symptom, the growing inability to cope with the day-to-day. Now, this could look very different for different folks, but it's really about being able to manage stress. Rebecca talked about being able to cope with the things that you do. And so with day-to-day, are the folks able to, let's say that they take a bus to their doctor's appointment or to drop off their kids at school, if they're no longer able to like coordinate their transportation, be able to say that A goes to B, or a person that can no longer, let's say, manage their schedule, keep an agenda, that sort of stuff, things that they were able to do before, or even like if they have 5 kids in the household or 5 family members in the household, and before they were able to actually have everyone there, manage their schedules, prepare the meals, clean the house, and all of a sudden you're noticing that the house isn't looking the same way. They're screaming at the kids more. They're not taking care of themselves like they were when you first came out. Those are all indicators that something's really like stressing them out or bothering them, or that something's going on where they're not able to manage the way that they were managing before. The other thing, and very, very important right now, is the presence of suicidal thoughts. Folks don't typically come out and disclose, oh, I want to kill myself today, or don't openly state that they're having suicidal thoughts. But sometimes, depending on the rapport that you have established with someone, how engaged they are in the program and the services that you're providing, they could have that trust develop where they can share that. But if you do notice in terms of suicide that folks are giving away their belongings, making statements that they don't care, that they'd rather not be here, it's always good to ask. And I know that that's something that we'll be able to talk about later on, but always gauging for suicidal thoughts. Sometimes there is a high correlation, actually 1 out of every 4 adults that has depression or is feeling depressed, is that the presence of suicidal thoughts is there. So there is a correlation, although not everyone that is depressed does end up suiciding. The other thing is substance use. If someone is using substances, they may use to self-medicate or to deal with emotional pain or whatever is going on in the household. It could be something else, but we also look for substance use as an indication that something might be going on in the mental health realm. So those are things that you can look at for in terms of adults. Now, specifically for pregnant or postpartum women, same thing would apply in terms of changes in mood. This is a very interesting period, as you all may know, because there's a lot of changes in hormones and loss of mastery. So mood changes is very important to note. But I think more importantly than anything is the bonding and the attachment difficulties that they're having with either the newborn or with the other kids in the household. Primarily the newborn, because that's the person that's going to be the most dependent on the mothering, on the new mother. Also looking for intrusive thought. And these women that are having postpartum symptoms might describe as things that just come into their head. They don't know where it's coming from. It's just 1 minute they weren't thinking about anything, and then the next minute it's there. It might be what happens if I wonder what would happen if I put the baby in the oven. Little things like that are very concerning, but they're just thoughts that they never thought they would have, or that just come in. Feelings that they should have never been a mother, or that this kid would be better off with someone else. And obviously, again, going back to that thought about worrying about hurting your baby. So now we're going to talk a little bit about the whole reason we're having this presentation, right? Being able to access care. What does that look like? Our department is huge, like Rebecca mentioned earlier, and there are many ways that we can access care. We're going to go over 3 of the basic ways, and these are the 3 most accessible ways of accessing mental health services, although one of the ones that we didn't list would be to basically just walk into one of the clinics. But these, again, are the most easiest ways. These are the easiest ways to be able to access care in our department. The 3 that you see up on your computers right now are obviously the DMH website, which we'll look at, access line, which is a 1-800 number, and our service area age navigators, and we'll also talk about that. So our website, it's dmh.lacounty.gov, and and when you log on to the website, it'll have several tabs on there. It tells you on our website what our mental health access number is, which is the 1-800 number that we'll be talking about in a little bit. But it also tells you the different tabs, different information that's provided on there, including public service announcements for folks that have suffered from some form of mental illness and are actually have regained hope and are on their path to recovery and to well-being. So on the website, if you note on this slide, there is a purple kind of magenta-ish box. If you go there where it says locate mental health services, it's denoted by the big red arrow on your screen. You can type in a zip code and actually locate mental health services. So if you put in a zip code there, it'll take you to the next page, which is a list of different specialty clinics or clinics within that zip code. And the list that's populated is actually a list that is a combination of both our directly operated clinics, DMH sites, and contract providers, which are community-based organizations or private agencies that have the contracts with DMH. And so they're also broken down by age groups. Some clinics are very specific in terms of the population that they service. So it's really important to pay attention to that. It'll give you on this site the name of the agency, the address, the phone number, and then whether they're an outpatient facility or inpatient facility, which is also very important to note. What I see, what I see on here is that it doesn't, on this one page that's populated, give you the age group that's served. However, if you click on the agency name, it will give you the breakdown of the services and the age groups that are served at that particular site, and also the languages that are spoken. Yeah. Rebecca's going to speak to you about the Access Hotline.
So with Access Hotline, it's our 800 phone number. Many individuals have used it, and I've attended some of your work group meetings, and there have been questions about how to use the Access Hotline. So I got more information so I can be very prepared for today's webinar. So this phone number, you can contact this phone number, and then you can give them the zip code or where you're looking for services, and you can let them know specific of what you're looking for, and the person on the other side that answers the call will be able to assist you. I asked them how long does it take on average to get the phone call answer, and 90% of the time it takes 1 or 2 minutes. They actually they get studied by Medical, actually get audited, so it takes about 90% of the time they answer the phone call within 1 or 2 minutes, so which I think is pretty good. One of the things about calling Access, you are able to do several things there. You can call to get resources, but you also can call them for emergencies, mental health emergencies, non-life-threatening, but emergency psychiatric response. For example, you have a client who's suicidal or homicidal, might have a plan, might not necessarily have a plan, or doesn't have it's expressing that this is something that they want to do and they need help, and you're with this person, you can contact the Access phone number, and they will then dispatch what's called psychiatric mobile team, and they will come to the home or the place where the client is at and access them. So this is one of the ways you can use the Access Hotline. The way of using them for resources, one of the things that I like, they can give the person, you as the caller, you as maybe helping the family, the home visitor, or if the family calls or the client calls and they are willing to give their information, they're actually able to make a referral for them through the phone. And what they do is that they tell them what they need, they ask a couple of questions, and then send through we call it a systems tracking, a referrals tracking system, SRTS. They send a referral or a request for a referral to an agency that has an opening. They send it to them, and within 14 days, they will then be contacting the client to let them know we got a request for services. We are calling you back to make an appointment or tell you when to come in. So that's another way of calling Access. So either, again, just getting a list of places that you can go to. So it can be as easy as that. Can you give me a couple of names of agencies, which you can also do on the website, or you're calling them to actually be referred to an agency. So they will make the referral themselves, and then within 14 days, that agency will be calling that client and then telling them when to come in. So again, that doesn't mean that in 14 days they will be seen. Within 14 days, they will get a call back in order to make an actual appointment. So that's one way. And then lastly, again, we use the Access Hotline a lot for emergencies. One of the things about the Access Hotline that is very important, and you can get a lot more information on our website, it's a national hotline, actually. So at a certain time at the end of the day, around 5 o'clock, not only do they take emergency calls, but they're also able to take, they use calls to do, for the county specifically, to do services, for translation services, for languages that are not the 13 threshold languages. So they have a lot of facets, a lot of functions. So it is a good number to have for you, for your resource. Now, a little bit about our service area navigators. Again, Geraldine said that there were 3 options. And again, she reiterates another great option really is to make contact or become aware or very well acquainted with a couple agencies near your area where you work, and then basically just calling them directly and say, hey, you have an opening. That would be another way. But the third way that it's general for everybody, it would also include contact our service area navigators. Michaela at the end tomorrow, or when she sends the slides or the link, she will also share some resources, and the names and phone numbers of the service area navigators will be included for your purpose, for you guys to utilize it. So the role of the navigator is basically to access services and provide linkage. A lot of our clients, one of the main roles of our service area navigators is working with our full service partnership program, so our intensive mental health services. So in case you find yourself, you have a client, a mother or a partner in the family, or somebody you're working with through home visiting, that you really think like, well, this person really has some really high needs. Again, if you go on our website, you can tell you a little bit more about what the criteria is, but basically something's telling you this is a little bit more. The person's responding to internal stimuli, the person has a serious substance use issue, there's a lot of aggression, maybe the family member, or it's a family member, maybe it's your client, for example, and like Geraldine was saying, the client was doing very well, but all of a sudden, you really are not meeting with this client anymore, her thought processes are weird, you're a little bit afraid that something's going to happen, then a little bit more than your normal, like I'm feeling a little bit sad, and you're seeing some other symptoms. It just, you would want to contact the service area navigator and consult with them first of all, or you even can make that for the FSP referral through them, and you can let them know who it is. Obviously, hopefully the family, you need to let the person know, the client know. Unfortunately, you have to let them know, we have this service, and then you can refer them that way. One of the things about service area navigators, what they also do, they advocate for clients. They work, and there's a service area navigator per age group. So that's child, TAY, adult, and older adult per service area. So technically 4 per service area. And their real focus, besides doing the intensive FSP services, is really to learn their service area, get to know their service area and the services in the service area, because they also have to provide support to our intensive mental health providers as well. So oftentimes, for example, we used to work very closely with full service partnerships for children. Our child navigators would know, for example, a resource for some of the child that are going through eating disorders, for example, or they have shelters for families. So they would know additional services based on the age group that they're working with and the service area that they're working at. So it's a great resource to have as well, because you can consult with them about other things related all to help somebody who has a mental health issue. I'm going to give it back to Geraldine so she can talk to you guys about making the actual link to mental health services.
Hi, y'all. So in terms of linking to care, we developed a little crosswalk here for you that you're seeing on your screen right now. So the first question that you definitely want to ask is there a mental health services need? And if you go back and just review the symptoms that we've mentioned earlier, if there are things that you're questioning and you feel like this person definitely could use some mental health services, then you would go ahead and want to determine whether it requires access and either go to the website, call the access hotline, the 1-800-854-7771, or contact your navigator, and those numbers again will be provided to you, or that contact information will be provided to you. If you are using our website or calling access, you can contact the agency directly, and what we try to really always make sure of or encourage is that folks that are making linkages actually follow through and contact the agency to find out what the intake times are, or if it's best to walk in, what would be better suited for the individual that you're making a linkage or referral for. And the reason for that is we don't know what the capacity of that person is that you're working with. Maybe they're open to taking the referral, the number, or the information, but not really following through with making the call. So it'd be best, one, to make sure that the number is a working number, two, that you can have a live person, and three, that you also know the information so that you can, one, document it and also follow up with the person or be able to call with them while you're there. And then three, if you are just providing the information, providing them with the appointment date and time that you've created and the contact person at the clinic, or just giving them the information in general. So again, this is a very simple path in terms of how to actually link someone to mental health care. So with that, we end our part of the training session, and I'm going to hand it over to Dr. Mike Sherman, who will present on the medical necessity for mental health treatment, obviously in young children in care. So here you go, Dr. Sherman.
Thank you. Good afternoon, everybody. One of the things I wanted to talk to you about today is take a look at some of the challenges in referring young children to mental health services. And, simultaneously, we know that providing intervention early on in a child's life is going to be the most cost-effective, reliable, and impactful means towards improving outcomes. There's a ton of research out there that shows that every dollar we invest in early intervention results in $7 of benefit to our society at large. And some estimates actually show higher fiscal outcomes. We know that early intervention improves the cognitive and socio-emotional development of young kids, specifically those who suffered from neglect, abuse, or other forms of trauma, including multiple replacements, being shifted from their biological family to other caregivers in and of itself is traumatic for a very young child. Separation from a breastfeeding mom certainly would be traumatic for a young child, a number of different things that we don't necessarily consider to be trauma with a capital T. Child welfare outcomes and placement permanency is significantly improved when we have early intervention from a mental health perspective. Additionally, we know that lifelong mental and physical health issues are addressed through early intervention as well. And in fact, pretty much all adult outcomes are improved when we intervene earlier rather than waiting until later on to provide intervention that's often less effective, more costly, and takes many, many more hours of intervention to achieve less effective results ultimately. Early intervention also results in improved functioning across the lifespan. So whether we're thinking about intervening with a young child for their benefit in the here and now, or for their, for their improved functioning later on in their life, the earlier we intervene, the better we're going to see them function throughout their lifespan. So it's really, really pertinent. So simultaneously, while we know all that to be true, we also know that identifying medical necessity is the most nuanced and complex when we're working with young children. We have to deal with the nexus of a number of different issues happening simultaneously. We have their overall development. Is it typical, or are there problems with their development from a developmental perspective, from a physical or health perspective, and from a socio-emotional perspective? Do they have challenges that require support from a multitude of different providers, including occupational therapy, looking at maybe allergies or medical conditions, looking at genetic anomalies, looking at a number of different factors that contribute to what we often see as very similar symptoms or behavioral issues, especially in very young kids. So a lot of these things are multi-determined, and we really have to do our legwork to dig deep enough to see what's happening. Additionally, we have the impact of all sorts of different things, including prenatal exposure to substances, prenatal exposure to violence in the community, violence in the home. We know that toxic stress definitely impacts the unborn child and produces quite a lot of outcome differences, even when they are detained from the biological family and placed in a new setting that might be very safe for them. But the prenatal exposure does persist way past that point, and we need to really look at that as a risk factor. There are many impacts of trauma, both on a young child that happen throughout early childhood and that continue on as they traverse different developmental needs throughout their early life. And that trauma doesn't simply go away on its own. It gets reconceptualized and reworked every single developmental milestone that they work through. And so in supporting families and supporting foster families, we have to help them understand that, you know, while this child faced a lot of adversity before they got to you, they are not simply going to be all better because they're in a safe location now, right? We have to take meaningful steps to help support them in navigating their developmental course. And the best way to do that is by linking them to a mental health service provider that's going to incorporate not just providing services to the child, but working in a dyadic fashion with the child and their primary caregiver together to support the developing relationship. We also know that there are a number of systemic barriers that address, that impact access to care, that impact how young kids get into services. And those things are fiscal, budgetary, they have to do with training, they have to do with, some folks who are decision makers at agencies don't necessarily have the most current understanding of early childhood development or trauma, or how, ACEs and toxic stress impacts on young kids' brains and their overall social-emotional functioning. And so access to care isn't always the easiest thing, especially once we get past our DMH directly operated services and out into the community. While there are definitely a lot of very well-trained and providers who are capable of providing these services, I think there are still some out there that do need additional support, and we're working on providing that. So this slide shows the guidelines for LA County for Medi-Cal mental health services. And what I want to highlight for you guys today specifically is that oftentimes for our new clinicians, especially in the contracted world, they're taught that medical necessity is equivalent to functional impairment. And that concept is a very meaningful one that comes from the adult system of care, right? Where if you have an adult client, you know what functionally they're supposed to do. They're supposed to be able to maintain relationships, have some sort of meaningful activity that they're engaged in, whether it's work or hobbies, manage their hygiene, engage in age-appropriate self-care activities. And if they're not doing those things, then that defines their need for mental health services. That serves as a functional impairment. However, if we start to think about a young child, especially if we're talking about a 2 or 3 week old or younger or somewhere around that range, it's really hard for providers who don't have specialized training and quite a bit of it to identify functional impairments, even though they do exist. And so for those folks, what we've been really focused on is providing them adequate training to understand that significant risk in and of itself, based on history, is medical necessity. And if you guys look at this slide, you understand that the first requirement is to have a diagnosis with an allowable included condition that's covered by Medi-Cal. Now, with the DC 0 to 5, which is the diagnostic manual for young children birth to 5, we do have a lot of conditions that are included there that are crosswalked over to either the DSM-5 or to the ICD-10, which we use for Medi-Cal billing. So that allows, number one, to be taken care of on our end through our providers. Number two is really pertinent because it has 3 criteria. And as I said earlier, we primarily teach only the first. The first is that you have a significant difficulty in an important area of life functioning, which is that functional impairment we spoke about. But the second and third are equally viable, and they read that the child has to have a probability of significant deterioration in an important area of life functioning, or a probability that the child will not progress developmentally as individually appropriate. The key word in both of those is that they have a probability of those things. A probability is 5%, 20%, 100%, whatever that percentage is. But there's a chance that they will not either develop appropriately or that later on they're going to have an impingement upon their overall functioning. So even if today they have no symptoms, but we know their history is severe enough to imply that they're going to have issues in these things later on, we are technically allowed to provide them mental health support. You also have to have an expectation that the proposed treatment will somehow improve their functioning, and I would hope that none of our providers are providing treatment with no hope of their treatment improving the functioning of their client, and that the condition is not solely due to a medical situation. And to clarify that, if you have a client who has cerebral palsy and that cerebral palsy diagnosis is having some secondary mental health related symptomatology, right? If the client is depressed about their symptoms, if they're feeling anxious about going to school because they're not sure how they're going to be received by their peers, that client is eligible for the mental health services to address those specific things. However, if you have a client who has a medical condition, diabetes, asthma, whatever it might be, and they have no associated mental health symptoms, then it's a situation that should be addressed by their primary medical physician and not necessarily mental health service. What we're doing for Birth to 5 clients broadly and to increase our capacity is providing training. There are a lot of trainings being offered for directly operated mental health programs for our contracted providers and also to our systemic and community partners, such as you guys, in order to increase the capacity, both in terms of service provision and in terms of identifying which clients are capable of accessing the system of care so that we can get them to where they need to be in order to receive services as quickly as possible. The other part is that we're trying to broaden our range of services. And so I think I spoke to you guys last year on a very similar topic, and we talked about kind of evidence-based programs and what those look like, whether it's trauma-focused CBT or parent-child psychotherapy, there's CPP, there's a number of different acronyms and different programs that are provided through this lens of prevention and early intervention. We also have intensive mental health service programs such as IFCCS, wraparound, FSP, and all three of those programs have really spent the last year trying to focus on increasing their capacity for servicing younger kids and their families. And we also have our prevention and early intervention strategies. And I don't know if somebody's spoken to you about the step care model, but the nice thing is now we have opportunity to provide mental health services that are kind of titrated appropriately depending on what the presenting issues are for clients who don't necessarily meet medical necessity, but are showing some subclinical symptoms. So it really does allow us to provide intervention at all levels and even earlier than kind of client's first diagnosis, which is typically what PEI services target. For you guys and for a lot of our community members, the question of how to best support Birth to 5 clients comes up. And I feel like taking a look at some of these factors is really pertinent. We always talk about teaming across systems, and within our county being as large as we are, we have a history of functioning in a very siloed manner, right? Kind of DCFS does their thing, DMH does their thing, public health does theirs. Our home visitors kind of have had to traverse those large systems in the past to gain access to information, to gain access to care. And our hope is that we're doing a better job of teaming with one another and also teaming with you guys to allow you entry into our system, both in terms of receiving information and sending clients up in both directions. Definitely advocacy is a big one. And I think for those folks who have an interest in advocating on behalf of their clients, I encourage you guys to continue to do that. Don't just make the referral and hand somebody a piece of paper with a phone number on it, but really follow up and manage the transition, advocate for a client to be seen if you feel like they genuinely need to be, because at times, providers will respond differently to a phone call from somebody who has lived experience with a client than they would to just a simple intake form that has a little bit of information about the client's background. So definitely advocate as much as you can. The other piece is that my encouragement to all of our staff that I've trained and that I work with is to begin with an assumption that young children, especially those that are engaged in services with Child Protective or the Department of Child and Family Services, can benefit from intervention, right? Historically, our assumption is, well, this client doesn't meet medical necessity and I have to figure out why they do. My suggestion is start with an understanding that our youngest and most vulnerable kids who have a history of abuse and neglect, that has resulted in them being removed from their parents and placed sometimes in many, many different settings, start with the assumption that they are at risk and they do meet medical necessity, and start to think about maybe reasons why they might not, right? Start to identify, does this child have an exorbitant amount of resiliency factors? Do they have excellent care and support? Have the parents done everything they need to do in order to reunify with this child? Are they having successful visitation? Is the child supported in navigating this experience? And if so, then maybe we might be able to make a case for why they don't meet medical necessity. But otherwise, the basic assumption should be that they can benefit from mental health services. And then the other part is, this work is hard. When we're working with traumatized young kids, we need to really understand that it's draining on us, it's draining on the systems involved, and we have to acknowledge both our personal barriers to providing the ultimate care that we're able to provide, as well as systemic barriers, and actively work to resolve both what's happening for us and kind of managing our own burnout, as well as working to advocate that the system become more responsive to the needs of our clients. So with that said, I want to kind of put it back to Michaela and see if there are any questions that folks have that they would like to send our way.
Thank you so much. This has been super informative. So we do have some questions coming in, and I'll go ahead and start from the top. And feel free to keep adding questions into the chat box. Just for those of you that weren't here at the beginning, everyone is muted and will stay muted, because when we have this number of people, there tends to be a lot of background noise. So if you have questions, please type them into the chat box. So the first one was, for the FSP program for intensive services, are the services only for the child or only for the mom, or does the program support the dyad?
Okay. So in general, only for 0 to 5, usually the program would include the dyad. For children above 6 and older, it would be specifically for that child and also for adults. So however, you have to focus on who the focus client is. For example, if the mother has a severe mental health issue, then at that moment you would really refer the mom to the mental health services. So it will be mom receiving the FSP services for her to get better. So now a child that would be referred to 0 to 5 FSP specifically would be somebody, kind of going back to what Mike was saying, has a history of possible maybe being detained from family, has had a lot of other issues, or is exhibiting some serious symptoms, for example, at preschool or early care or child care, even biting, a lot of constant crying for like hours at a time. There's something going on. So those are symptoms that you can easily see, I think, but the more difficult symptoms that you can still refer to us, for example, would be maybe a mom that is having some postpartum depression. It seems like it's really affecting the attachment. Again, like Mike said, you're seeing that maybe the child's not really developing the way the child should be. For example, the child's 3 months, is not really gaining weight. You're seeing the mom's symptoms are getting severe, but really this is something like a change for the mom. Mom was doing well maybe when she was pregnant. You would be referring and specifically noting that there are some symptoms with the mom that's really affecting the child. The child is not really seem to be developing as the child should be. So that would be like a 0 to 5. When you look at the FSP referral, it will be a 0 to 5 section, and then you will let right there indicate the mom has or the parent has some mental health issues going on, or one of them being preschool, not doing well in preschool. So that would be like an example of the child that you would refer. So through Child FSP, they can provide some services for the parent. They can provide therapy for the parent through what's called FSS. Yes.
Okay, thank you, Rebecca. So the next question, I'm not entirely clear on what the question is, but it says, I have families that are required to get mental health services by children's court for parents. So I think they're asking about if there are any services for court-mandated mental health services that DMH offers.
So the challenge would be, because I know court often mandates services for parents who don't actually have any symptoms. They just want them to seek support and counseling to address relational issues or things along those lines. So I think if the parent meets, again, medical necessity criteria, that would be why we would take the client and provide them mental health services. The court order in and of itself doesn't make a requirement for us to provide them services. It's a requirement that the individual seek out services somewhere. The challenge is, again, if the parent meets medical necessity, there are certainly many adult programs where they can and will be seen for mental health support and services. Whether there's no way to know that until they're assessed and evaluated. And so the general step would be to refer them and then follow up to see if that, you know, if their case was open, if they were accepted for treatment or not.
And typically, BCFS actually has a section, their back-end workers that can provide information in terms of agencies they can go and receive that mandated treatment from. Typically, our clinics do not provide court-ordered treatment because the court specifically, like Mike said, specify the type of treatment that they want, and they require an X number of reports that our clinics will not provide. And so again, if mom needs medical necessity, you're always welcome to access the website, provide the referral list, and have them contact each agency. But working from an adult world, unless they meet some sort of need for services, the specific type of services would be very limited.
Okay, thank you. So then we have a few different questions about the access line, so I'll try and sort of combine them so you can address them all at once. The first question is, when we call the access line or PMRT for a suicidal client, do we need to assess insurance status, or is that service open to clients who are privately insured?
So access line actually for the psychiatric mobile response team takes any and all calls regardless of medical insurance status. We, when a PMRT call is taken, we go out and evaluate if someone is in a danger to themselves, to someone else, or are gravely disabled. So we'll dispatch regardless of insurance status. That is not something that the person that's calling access needs to learn. If they do learn it, then that's great. It would help us along the way. But if they don't, then that's also okay. The one thing that's really important to note, though, when there is a PMRT request made, that the requester, the person that's calling in for the service or for the evaluation, be present and lay eyes on the individual that they're making the call for, because if they're not available and on site when PMRT gets dispatched, the team will not dispatch.
Okay, thank you, Geraldine. So the next questions about access are about sort of what happens once access is called. So one question is about how a home visitor might prepare their clients for what to expect when using that service. And then the other question is about whether or not the staff who respond to a call on the access line have been trained in trauma-informed approaches.
Okay, so the first question of what to expect. So when you call them, you will be asked actually if it's like an emergency or will be for something else, because they have to reroute you. So when you're asking for something else, meaning you want resources, once you get somebody on the phone, they will be talking to you about what they're feeling. You don't really have to have that much preparation. You just need to let them know what you're seeking, because they're not going to be necessarily doing an assessment of what you do, only if it's an emergency. Now, if you're thinking that if it's an emergency and you need a PMRT, that's a little bit more different, because you have to see what's going on, who do we need to send exactly. For example, sometimes it's not even PMRT. Sometimes it's us access calling 911, for example. But for just getting a general referral, they're going to ask questions along the lines, okay, what's going on? What is it? Is it for you? Is it for somebody else? If it's for the mom, for the child, for example, usually, they speak to the mom, and then that's when they can ask them. I mentioned it in which that if they are willing to give their information, some families are not, and they just rather get a list of referrals. So it really depends on them. But some of them are willing to say, I want to be referred somewhere. So they make a referral through our systems tracking referral system, and which is called SRTS. And again, they make a referral to an agency, and then within 14 days, that agency's the family has to be giving their phone number and address, and then within 14 days, they contact that person and let them know, okay, we got your referral. This is the date that we have available for you to come in. So that's what happens. So those are no way. So the other question regarding being trauma informed, so that would be more for like the emergency people who are going to have, like, for example, this is an emergency. But in general, most of our staff in DMH, or if anybody, we actually have all been trained in trauma-informed care. Some of us have received more training than others, but specifically for our access line, they are trained constantly how to receive and how to engage clients as well, because even though it might not be an emergency, or they might not click that is an emergency, it may become an emergency within a minute. So they are fully trained to receive those type of calls.
Okay, two more related to PMRT. One is approximately how many responders are there per region or per SPA? And then the other one is, I know you just said it generally takes about 2 minutes for a call to be answered. But the question is, how long does it take for PMRT to respond? I think that means in emergency situations to actually arrive at the location of the emergency.
So the psychiatric mobile response team is actually a service that's available during the day, during regular business hours. And for that, we have various teams that are available, broken up obviously by service areas. And depending on the number of teams and the nature of the calls, there's no fine logic model or equation that will give us an exact number of or exact time measurement of how long it would take to respond. That's not something we can really state. After hours, which means after 5 o'clock to 2 in the morning, those are folks that are volunteering for shifts after the regular business hours, so folks that work during the day. So it depends on the availability of the number of teams per service area. And because we cover countywide from SPA 2 to 8, the number of teams available respond to whatever X number of calls there are. So there's no fine equation. SPA 1 has their own team. Mike is asking about SPA 1. SPA 1, Service Area 1, the Antelope Valley, because of the size of Antelope Valley, we have our own designated services up there that are still PMRT bound, but their team particularly provides services only for Antelope Valley. So for SPAs 2 through 8, service areas 2 through 8, it depends on the number of teams that are logged on. For example, on a given Thursday, what is today? Today is Wednesday. So for today, in one service area 5 per se, we might have 3 separate teams signed up for service area 5 and only 1 team signed up for service area 8. And if we don't have any other teams signed up across the different service areas, then those 4 teams have to take the prioritized calls in the community based on whatever, whatever's given to them and how they dispatch. And there aren't any specific factors that will give us an equation. And I'm sorry, I don't have a straight answer for that, but it depends.
And just Rebecca, just to add, I think the department's also aware of the need to have more teams. So one of the things is that by law and to protect our clients, you have to have a specific training to be able to put people on a hold. So it's not just you being licensed or you're just being, having some experience. There's actual expectation of doing extra trainings for it. So it's a little bit more specialized, and that has to do with the fact that we want to make sure we protect our clients' rights.
Okay, thank you both. That was really helpful. So another question is, under what grounds should be raising a flag to send 0 to 5 children to therapy? So I wonder if maybe you want to put back up the signs and symptoms of mental health issues in young children. And while you do that, go ahead.
I was going to say, I think that's a great question for Dr. Sherman.
Okay.
So again, I think it's always a good idea if you have a child that has suffered abuse or neglect, that is involved in DCFS and has had exposure to prenatal substance abuse, exposure to significant trauma, exposure to domestic violence. All of those scenarios, in my mind, warrant a referral for an assessment evaluation. At that point, it no longer is on the home visitor to determine whether that child meets criteria for services or not. That then is the determination by the treating provider. Again, I think the access to care issue is a significant one, and it's one we're trying to address. But the challenge is that, the eyes can't see what the mind doesn't know. And we have a number of providers out there who, although they are trained in intervention for birth to 5, I think that the focus primarily is on kids who exhibit externalizing symptoms. Mm-hmm. That is, they're doing too much of something that gets in the way of their preschool functioning, that gets in the way of their home functioning. They're crying too much, they're biting too much, they're hitting too much, they're out of control and running around too much. And those kids typically get into services. Where my personal concern lies and what we're trying to address is the kids who show internalizing symptoms, the ones that are anxious or depressed or showing less engagement that we would typically want to see. And what we notice traditionally is what happens with those kids is they get into the foster care system and foster parents say, well, this little guy's an angel. He's perfect. He doesn't bother me. He doesn't cry much. He doesn't ask for much. He's great. And they're not a tax on their time. They don't get in the way of their other daily activities for the foster family. And oftentimes, for me, that actually raises a larger red flag, because if you think about what that child has just been through, right, with the detention, with the trauma that they've suffered, they should be crying, they should be distressed, they should be distraught. And if they're not, that's a significant concern and a big red flag for me. And I would certainly refer those kids as well. So kind of think about how you would feel woken up at 3 a.m., pulled out of your home, missing all of the things you're typically used to, and didn't have words to share your discomfort, didn't have a great understanding of what's going on, and how disorienting that must feel and how traumatizing that must feel. And with that in mind, think about placing yourself in the shoes of these little ones and what they're going through. And that's where a lot of our training efforts are focused and a lot of our advocacy efforts are focused at these kids who later on are going to present with very significant symptoms more likely than not. And we know that children detained by DCFS, 80% of them are at risk for developmental delay. We know that quite a few of them are at risk for mental health concerns later on in their life. And the earlier we intervene, the better the outcomes are going to be. So it's in all of our interests to provide that intervention. And I would lean on referring kids more often than not, personally.
Thank you. That's a really... Oh, sorry, go ahead.
Okay. I just wanted to add a little bit to that because I know many of the home visitors were saying that maybe they're not being detained by DCFS. But one of the things just to reiterate, a lot of times they're aware that there has been domestic violence, that the father or the partner is no longer in the home. So those are, again, just to reiterate, if you have that type of information, you should be referring. You don't even have to wait to see symptoms, because just the fact that they're so young and they're experiencing this trauma is obviously symptom enough to be referred.
Thank you. I think those are really good reminders. The next question is, what referrals do you provide for undocumented individuals?
So when it comes to services, mental health services, we don't ask people if they're undocumented or not. We go based on if they have ability to pay. That's the reason why the slide that we talked about, who is our population, and I'll go back to it for you guys to see it a little bit. We have people who have Medi-Cal, which obviously you would have to have some form of documentation in order for you to obtain that. And then you have indigent funds and sliding scales. So indigent funds would be for clients who either are undocumented or unable to be insured or uninsured or at a very low income. They don't necessarily have to pay anything, but they will be under indigent. So and when it comes down to what services, our programs, all our programs have some form, take some indigent funds.
Great, thank you. The next question is there home visitation available for postpartum women who meet medical necessity but who do not meet criteria for FSP?
So again, going to one of the programs that is a between program, it would be under outpatient, our triple R program, or recovery, resilience, and reintegration program. It's a marriage between general outpatient and in-home services. This program basically, it used to be called FCCS. It was really the step down for FSP, or you can consider it the program that is between general outpatient and intensive mental health services. In other words, they don't really meet the criteria for intensive services, but they need in-home services. In fact, this program, when it was called FCCS, was actually began with with our older adults program, because many of our clients, due to their physical advanced age and some being fragile, they wouldn't be able to come to the clinic. So this was one of the programs that was actually to target them, and eventually it started opening up to all the age groups. So it is one of those programs that is available that will be able to provide in-home services, but you don't have to be intensive. One of the things though about triple R, which because is to have in mind though, is that you don't have all the services that the intensives do, but you do have the therapy. You can have the case management, and some of the programs also have parent partners or peer advocates. And also, eventually, though, the plan is that once the person's a little bit more stable, they will be coming into the office. Right now, the way Triple R is looking is one of those programs in which some of the clients might start being seen in home, and then as they get better, they get to be seen in the clinic. And the good thing is that we don't change the therapist. So like that, it could be a continuum of care.
Okay, great.
Just to add, I'm sorry, for Triple R though, unlike FSP, everything is at home. The intensive services, so even the intake, the actual assessment would be done at that home or at the child's school or etc. But with Triple R, the intake is going to have to be done at the office. However, after the intake, if the family really requires services at home, then the services can continue then at home. I just wanted to share that with you.
Okay, thank you. So the last couple questions are about relationship building on a regional level with the DMH offices in the area of the home visiting programs. And in particular, there was a question about how to try and create a memorandum of understanding for a service partnership with local DMH offices. So I know, as you mentioned, I'm going to send out some materials which include the contact information for the mental health navigators in each region. Is that the best way to start forming a relationship, or is there another route that you would recommend?
So, if it depends on which programs we're talking about, but I think when having to deal with the child welfare sector, which I'm kind of a little bit more comfortable talking about, I think that, I would certainly agree that relationships are really key to functionally assisting our clients. The better we're able to develop and maintain those relationships, the more optimal our services are going to be across the range of both of our networks of care. In terms of MOUs and such, each service area has their own program managers and district chiefs for pretty much every program you can think of within DMH. And so I would attempt to attend the service area meetings and start developing those relationships and have those discussions with the service area folks. But to be honest, I don't think any of us in this room currently are in a position to respond to requests for memorandums of understanding or any such documents.
Okay, great. So we are actually pretty much right at time. I want to thank our speakers for all of that information and for answering our questions. That was incredibly helpful. And thank you to the folks on the line for asking all those great questions. Just a reminder that the webinar has been recorded, so we'll send out a link to the recording as well as copies of the materials and some additional resources that the speakers prepared for you. So thank you all again, and thank you especially to Geraldine Gomez and Rebecca Hurtado and Mike Sherman for your time and all of that information. And with that, I think we will close there and enjoy the rest of your afternoons.
Thank you so much.
Thank you.